Okay, this is our monthly podcast. We talk about mental health topics, and we this month we have Dr. Starkman who's going to join us, who's joining us about what I think is a really interesting topic that maybe doesn't get enough airtime or conversation about. I don't know. There's a lot of stuff I think in our world about healthy eating or self-care or taking care of one's health, right? But I think this could be quite an interesting perspective given your background as a psychologist. So could you maybe just give the audience a sense of kind of, you know, where you are now, the kind of work you're doing, and then we'll get into sort of talking about some of the specifics.
Yeah, absolutely. I'm Dr. Charlie Starkman. I'm a licensed clinical psychologist. I'm currently the assistant director and the director of training at the University of Michigan Dearborn Counseling and Psychological Services Office. So my responsibilities are kind of a blend of like clinical, supervisory, and administrative work in the University Counseling Center. So my specialty is really working with late adolescents and emerging adults, and I've been in that role for the last 6 years as of October. So really love what I do. It's very meaningful work. It's a fun blend of like a pretty consistent 8 to 5 schedule, but no 2 days really look the same. So I enjoy that. Keeps me on my toes.
For sure.
I also am part of group practice, My Body PLLC in Birmingham, where the clinicians really focus and specialize on treating eating disorders and other kind of comorbid conditions. So have small role there.
Sure. Interesting. And so your kind of the bulk of your day is through your role as a supervisor or as like an educator or a clinician, right? And then how maybe like I don't know, 10 clinical hours a week or so? Like what's your schedule like in the private practice world?
Yeah, so I usually carry at the practice between like 10 and 12 individual clients. So most of those I'd say I see like every other week, but I probably
Right.
see about like four or five of the my practice clients during the course of a typical week, just based off the
For sure.
schedule.
For
And
sure.
yeah, so
Makes sense.
it's a good balance. It's a good balance.
For sure. And the practice is focused on it's kind of like primarily focused around sort of eating disorders, things like that.
Mhm. Yep. And I would say the vast majority of clients that are seen at the practice also usually have something else going on. Mostly anxiety disorders are really common. Most have a history of trauma, um, depression, or other mood disorders, substance use issues.
For
So
sure.
the general comorbidities, I guess, that you'd see
Right.
alongside eating disorders, because those usually don't just happen in a bubble.
Right. That makes sense. Well, again, the goal of the work that we do in the podcast at least is to try to make topics that are unfamiliar or nuanced be more kind of understandable and try to help our audience be more able to kind of think about, okay, what does this look like? Or where can I get help? Or how do I make sense of some of these challenges, right? Because there's a lot of,
Yeah.
it can be some degree of not always helpful information on the internet that one might come across. And we
Yeah.
try to address some of that, to try to sort of unpack some of those things and talk about them from a kind of professional experience perspective. Um, how did you get into that specialty, or what got you interested in doing that kind of work? The kind of work that you're doing now.
Yeah, it's a great question. So in my first clinical practicum in my doctoral program, one of my rotations was actually working on an eating disorder inpatient unit for adults. So I was doing a blend of psychological testing and also leading therapy groups. And I think the clinical work was great, but I was actually really drawn to sort of the multidisciplinary approach that you really have to take with eating disorders,
Hmm.
because when it comes to dietetics and it comes to the psychiatry that you have to blend, and working with a family therapist and so many other
Yeah.
people, it deepens the work that you're doing. And I found that I enjoyed when I was able to kind of see see the progress, but also recognize the challenge. Because I think one of the biggest tips that I always give to clinicians who are either interested in kind of moving into working with eating disorders and kind of developing that skill set is you have to be really comfortable with sort of the like 2 steps forward, 4 steps back, realizing that progress
Mm.
is not, progress usually in therapy isn't linear, but in less complex presentations, sometimes you can see that growth faster, the progress faster. With
Yeah,
eating disorders, you have to be comfortable with not seeing that happen as quickly, even if you're a super talented clinician.
for sure. Right, because of course, one of our, I think, sort of humbling realizations as clinicians is it's a it could be more, but it's at least a two-person process, right? There's you and the work you're putting in and your experience. There's the patient, the client, kind of where are they in their life? How much are they able to kind of make use of the treatment? And the
Yes.
progress, of course, is typically we sort of think of incremental, small steps, right? So I can really relate to what you're saying. Is we wish that we could say, oh, come for treatment and we'll heal you, but it's really
In 6 sessions or less, yeah.
for sure, right? Doesn't
Which,
doesn't always work, or usually it takes a lot longer. But how? Okay, so speaking of kind of multidisciplinary, right? Which I think is we probably don't have enough in all kinds of mental health aspects. Don't have enough collaboration with other specialists sometimes. What does that look like in the eating disorder world, and what role, like, if you could, there's a role, of course, for the
yeah,
psychologist, but what role do people play? Like, how does the team, in a good sense, whether it's inpatient or outpatient, how does the team work together?
yeah, absolutely. So I think that coordination of care piece is so important. Trying to set up, I always try. It's always my intention to get in touch with a patient or clients, psychiatrist or dietitian, or if they have a case manager or someone else that's involved in their care, at least twice a month. That's always my goal.
Okay.
Just to be able that we're on, to make sure that we're all on the same page. That the dietitian, if let's say a client has to be weight restored, or if they are currently weaning off. I'm thinking of a client I have now weaning off laxative abuse, right?
Mm-hmm.
Thinking about the ways in which dietetics is kind of working to get them towards that space, how
I
they're
see.
how they're working. If there are changes being made in medications, what does that look like? How do I maybe need to address my approach therapeutically? Being able to talk to anyone else who's involved in their day-to-day functioning, whether that's a parent if they're an adolescent, or a
Mhm.
spouse. Just being able to really make sure that everybody's on the same page, and that we're all focused on treating the disorder together,
Yeah.
and recognizing that the more that everyone's siloed, the harder it is to um, really make sure that treatment's as effective. It has to be a collaborative process, making sure that we're all working
For
together
sure.
with interest in mind. So that's a really good question.
Sure, that makes sense. And I see, Bill, thanks. I'm glad you were able to
Sure.
join. We were
Yeah.
just we were just talking with Dr. Starkman about his. We kind of started off on how he got involved in the world of eating disorders and kind of what got his interest, doing that, and especially about how it's such a complex work that involves a lot of people, right? I think Charlie, you were just saying that, like, I can see how if somebody's trying it, the changes one has to make have such an impact on their health and their body and their well-being that having a dietitian, for example, I can see how that could be really important because the changes, the food we eat or eating enough food or kind of having enough nutrients is so important to having a healthy life that having that kind of professional input, I could really see how that makes a difference.
Yeah, and if I can just add one thing really
Yeah.
briefly, also super important when you're thinking about a client's engagement in therapy too. If someone's malnourished and they experience what we call like cognitive dulling, they're not able to really be present in their treatment. A big part of those early stages of treatment, especially if is underweight, is that nutritional rehabilitation, being able to make sure that they're in a place where they're stable medically, where they have enough psychological functioning that they can actually engage in the treatment process. So that is also why the dietetic piece is really important. And a therapist can't do that on their own, especially if someone is early on in treatment or has unique needs that need to be addressed.
Sure. No, that's super interesting. But one of the things I wonder about sometimes when there's a call or a patient maybe is looking for this kind of help, one of the
Yeah.
things I think about is how do you determine the location of care? Meaning, do they need
Yes.
inpatient, partial,
Hmm.
hospitalization, outpatient, some combination? And I'm sure that could vary depending
Absolutely.
on so many factors. But how do you make that determination about, is this a more of should the person start an inpatient, for example, right? How do you think about things like that?
Absolutely. So, unsurprisingly, the goal is always to make sure that we can keep a patient at the least restrictive care level of care as possible. And I think that makes a lot of sense. The last statistics I saw, about 90% of eating disorder cases can be addressed at an outpatient level
I
of
see.
care,
I see.
especially because unfortunately the most severe cases are often the ones who are most reluctant to actually receive treatment or just not at a stage of change where they can fully engage in the process, and that's
Hmm.
okay. For me, I'm always thinking about levels of care just in terms of whether or not a person is able to keep themselves safe, whether that's suicidal thoughts or if they're severely medically compromised,
Sure.
then I would certainly recommend inpatient. If they maybe are stepping down from inpatient, but they're not at a place where they can just have, where they need just like an intensive outpatient, like a 3 day support, then I look into a partial program where
Yeah.
there's increased structure. And let's say, a person is struggling and is concerned about like having a lapse in recovery, like they've had a period where they've been kind of what's called like in remission, where they haven't been experiencing symptoms, but maybe they just experienced a major life transition, or there's been a recurrence of like a depressive episode and they're worried that that's going to impact their recovery. I might
Yeah.
suggest stepping up to an IOP for a few weeks just to get that stabilization piece, which I think is really what like an IOP is there for. Um, I actually did recently have to step a client up to residential, and they were not happy about it. And I can't force, I can't
Which,
unless someone is an acute safety risk, I can't commit anybody. I don't really have that power in the same way. If they're medically compromised, a doctor or a physician would have to take that step and support from the rest um, of the team. But all I can do is make that recommendation and have to be able to set that boundary with the client of like, I can only do so much. I think all clinicians can get to that point with the
for
client,
sure.
regardless of the presentation. I
For
sort of
sure.
think of it as like the end of the road, and that's not necessarily a bad thing. It's just, sometimes a client just either needs another perspective or they've kind of done what they need to do in therapy or what they're able to tolerate or kind of handle at this time. And that's okay.
I really appreciate that. And also sometimes changing the level of care, like if, let's say, they need to go to a partial
Hmm.
hospitalization or inpatient, that can actually help them make further progress because maybe they need
Yes.
a sort of a stabilizing environment, right? And they need some additional help. In outpatient work, we typically think about if the person's sort of, yeah, they're kind of able to take care of themselves, attend appointments, and sort of work on their emotional, psychological coping skills, things like that. Then that's the patients we try to work with in outpatient who are sort of more able to
Yeah,
maintain that kind of routine, right? And when they're not
exactly.
able to, they need some additional help and additional support. That I could see them.
Because eating disorders thrive in a lack of structure. And so clients tend to do well, or at least can kind of get back on a road of progress when they've been able to reestablish a sense of structure, whether that's more structure with like, with their eating. Obviously it's one of the most important things, but
Sure.
just with establishing a healthy routine, whether that's working full time or going to school, navigating other responsibilities. I think eating disorders often really thrive in chaos. You see a lot of symptoms develop during times of major upheaval or transitions, loss, grief. And so being able to just help a client establish that structure if they've lost it is sometimes why a higher level of care, more like an IOP or a PHP, can be helpful if there isn't the same degree of like a medical complication.
For sure. That makes sense. Um, Bill, this may be a good chance to kind of pause for a second. What we try to do, Charlie, is we try to, well, Bill he's a neuropsychologist. Bill, you can speak for yourself, but he may have a few questions. But also, um,
Sure.
we try to invite the audience. So I know we have a few participants here. If the audience at any point during our talk, there's a Q&A feature where you could put in your question. We don't have to announce it's anonymous, but I'm sure, Charlie, you be curious about what questions the audience might have, and that's another way
Absolutely.
to kind of engage and sort of make use of the time we have together. Um,
Definitely.
so, Bill, I don't know if you have any thoughts or kind of anything you.
Yeah. I'm glad that I was able to join. I don't really treat individuals with eating disorders, but of course, as a psychologist, they always present in our practices in one way or another. There are two questions I have really. One is, do you notice any differences in diagnosis or treatment trends for gender influences on care?
Yeah, absolutely. I think, for a long time, eating disorders were characterized as kind of, a women's disease. But I think over time, when it comes to gender and just patterns that we're seeing, you know, even though there is still a pretty disproportionate presence in treatment centers or just in general of women kind of either seeking out treatment or just the predominant population, see a lot more males concerned about body image, especially muscle. There's kind of it's the non-scientific term, but it's kind of been coined like bigorexia. So that desire to gain more muscle mass, really kind of thinking more about like what masculinity looks like. And so those are definite considerations that you're keeping in mind. I enjoy working with male clients when they present. Typically, um, the one presentation that you'll see more of kind of an even gender split with presenting for treatment is binge eating disorder. There's not the same degree of like a gender disparity than is typically shown in either anorexia or bulimia. So I think that, it's obviously important to be able to tailor that treatment depending on how the client's presenting and different facets of their identity. But I do think that you're starting to see more men seeking out treatment, and I think a lot of times too, um, and I think a lot of times people see bulimia and purging behaviors, compensatory behaviors, as just self-induced vomiting. But we have to also think about excessive exercise, periods of fasting, men who are engaging in sports like boxing or wrestling or anything that requires losing weight very quickly and thinking about those patterns. And for women, oftentimes I've worked with ballet dancers, figure skaters, sports or activities where body image and weight are so
Yeah,
central and emphasized. So those are all things that I'm always keeping in mind.
that, that makes sense. Um, Charlie, I wonder if could you say maybe something about from a psychological, emotional, developmental perspective,
Sure.
how how would you under how might one there's many pathways to right, like people have different walks of life, different experiences, so there's not one way to understand any sort of symptom or condition, but from a psychological point of view, what's the mechanism of, why does somebody turn to binge eating or eating difficulties versus some other, not maybe helpful coping approach, right? How can you say anything about, does it have to do with development? Does it have to do with culture? I'm sure it's all the above, right? But I'm just curious, what do
Yeah,
you see? Like when you get to know
sure.
some of these clients and you work with them, you get to sort of understand, oh, I see how they got to this way of taking care of themselves that doesn't seem to work and they really need to help with that. How do you think about that? How do you kind of make sense of it?
I think that's a great question. I think that I will always say that I think a chunk of it is linked to how for clinicians and folks who, might be tuning in who are doing clinical work, a
Hmm.
lot of that does kind of link back to your own orientation, the way that a psychoanalytic or dynamic clinician looks at eating disorders is going to be different from the way that I practice, which is more of a cognitive behavioral, like third wave behavioral approach. So I really conceptualize a lot of my clients' behaviors, especially when it comes to anorexia and bulimia is rooted in kind of this notion of avoidance and excessive control, right? When it
Hmm.
feels in life like so many things are spiraling, right? Or for development, I think of like physical development, right? With physical changes for a woman, let's say, developing breasts, or the discomfort of those changes, it's easy to turn to food or to turn to weight as a way of exercising that control. Let's say that there are significantly strained family dynamics, and there's a lot of research behind that notion of like high levels of expressed emotion within the family system, right, is contributing to the emergence of an eating disorder. So then you
Yes.
think about, again, how can a person avoid the difficult or painful internal experiences that are coming up, right? And very often it can be linked to ways that they can control either what they put into their body, the way that they modify their appearance. If
Sure.
they're an adolescent, there's obviously a lot less they can do to control any sort of discord that's going on at home, right? So they think about, okay, where can I try and find some semblance of control? Sometimes eating disorders are also a form of communication. They might be communicating um, that they're in pain. Sometimes I conceptualize bulimia a lot of times as, you know, the notion of purging or compensating as a way of just emptying the self of painful emotions, especially disgust, guilt, shame, right? So we think about all the different ways that we can understand how a person is trying to kind of make themselves feel better.
Sure.
Um, Even, I always think that an eating disordered eating, however you want to frame it,
Hmm.
that always starts off with good intentions. Like, a client who just wanted to lose a little bit of weight, and then it just started to spiral into something very different, or you know that they you know that they liked the feeling that came with not eating, and they
Hmm.
didn't want to do it all the time, but then that feeling just started to become very comforting, right? Or the use of food in binge eating disorder, right? There's very strong connection to self-soothing, like you were saying. So I hope that answered the question, but
Yeah, no, definitely. I think so because is another way is another way to say that it's a form of self-regulation or emotional regulation. Is that
absolutely.
kind of an accurate way to capture some of that?
Yes. And so I will definitely do a lot of DBT skills training with my clients, really that focus on distress tolerance and emotion regulation, like really being able to kind of think about what are alternative ways to be able to help yourself feel more more together, more regulated
Yeah,
when it feels like everything else is, you know, is kind of is spiraling out of control. And also, we know, and this is just kind of a general thing, like we all know the word like hangry, right? Like when we're not eating, when we're not taking care of ourselves, it's going to throw off everything.
sure.
It's, mood, sleep, it all really starts to kind of crumble.
Yeah,
And so sometimes just being able to utilize those kinds of very simple, like skills training, psychoed interventions can be helpful in at least starting a client on, um, you know, on that path towards, seeing
sure.
small changes.
There's a question. Thank you, Charlie. There's a question here from the
Yeah.
audience. I think you kind of touched on this a bit, but I think it'd be
Yeah.
useful to return to. The person asks,
Mm.
do you accept patients for services such as a dietitian, psychiatrist, or family therapist at your clinic who are currently receiving outpatient care somewhere else? Meaning, like, I think what they mean is, let's say the person
Yeah.
is
Great question.
over here, over there, right, and they have some kind of eating difficulty, self-care difficulty like that. Would
Yeah.
you be able to work with them or see them kind of in addition to them getting help somewhere else, right? I think that's kind of the question.
Sure. I think that's an excellent question. And at my body, especially for dietetics and psychiatry, we definitely would. Sometimes therapy, as I'm sure doctors Babushkin and Bloom know, that sometimes when you have like multiple therapists involved in a case, I always call it double dipping. That can be really difficult.
Yeah.
I'm not a fan of it, and that typically does not bode well. A lot of times with eating disorders, you'll have a client, have want to see a therapist solely for the eating piece, right? But
Mm.
they see another therapist to address their maybe an obsessive compulsive disorder
Yeah.
or for trauma, right? And then they see you and they're just like, I don't want to talk about those things, but they all intertwine, right? And
Sure.
so therapy then becomes extremely ineffective because they're noticing, wait, I'm still talking about my anxiety, and it
Right.
becomes really messy.
Sure.
So I think with therapy, I will always, because I've not seen that be very
Yeah.
effective. Well, I will kind of talk to the client about, we have to I'm going to ask you to make a tough decision here. Like, what do you feel like you are really needing to work on more right now? Where do you
Yeah.
feel like you're ready to direct more of your energy in your therapeutic work? Is that addressing the anxiety, OCD, trauma, whatever? And probably the eating disorder is coming up in that work as well. Or do you feel more comfortable working with me, taking a bit of a different approach and
Yeah.
making kind of more of the focus, right? So therapy is a bit more difficult, but we definitely see clients for dietetic services.
Mhm.
We have we have a psychiatrist on staff. I will say that for most of the clients, they are kind of referred in house. But if they are looking, especially for a dietitian, we
Yeah.
have a few dietitians on staff, and that's always something that we're willing to um, we're willing to work with.
Sure,
Um,
sure, sure. That
yeah,
makes
that's an
sense.
excellent question for sure.
And I can appreciate what you're saying, especially going back to the sort of self-regulation part, right? That when you're working
Mhm.
with these eating difficult challenges, I guess, right? You're
Yeah,
you're really thinking about it from a much more broad, holistic view of who's the person, how did this develop, what does it do for them, what does it not do for them, what
yeah,
problem are they trying to solve? If the problem they're trying to solve is I feel bad, I don't like my emotions, I don't like myself, I feel
mhm.
out of control, and the way I can solve that problem is through something having to do with food. In a way, it, I guess, solves one aspect of the problem because maybe they feel better temporarily. It does something for them. But of course, it's
Yeah,
not a very it's kind of a maladaptive sort of solution. And so if
exactly.
yeah, you're not just saying to them like, oh, we're just gonna talk about eating, so to speak. You want to know them as a person. You want to know how they
Yes.
function, right?
And it's very easy for this is something that you see very often in eating disorders that the client often presents a lot with kind of that black and white dichotomous sort
Okay,
of thinking and wanting to really kind of compartmentalize and
I
break
see.
things into chunks, right? So for them, it's safer to have the therapist where they feel like they can just talk about this, or they're the therapist where they can just talk about their eating disorder, right? But they start to see pretty quickly that like trying to always keep that balance going and sort of juggling those two things is really just not going to work. And so that sort of that tendency to be very rigid is one of um, the key things that you see in
For sure, sure.
especially anorexia and bulimia, a bit less so with binge eating disorder, but it's still something that you have to really be on the lookout. But I like the way that you framed in terms of helpful versus unhelpful, adaptive versus maladaptive, because it goes back to how I initially like think about the clients that I work with. Like this started off with good intentions. This
For sure.
started off as trying to be something that was meant to be helpful for you.
Sure.
Unfortunately, it morphed into something that became unhelpful for you. So let's talk about that. Let's look a bit deeper into how it got to that point. So I like that. I
Sure.
like that you thought of it.
Yeah, thanks, Shirley. I appreciate it. I try to use those words. I think adaptation I find as a therapist, I think about that a lot because almost everything we do is one degree of adaptation or another. How well does it
Yes.
work, and can we
That's
modify,
another
right?
story.
Right. Charlie, what about so you mentioned cognitive behavioral approach. That's one aspect, but I'm
Sure.
really wondering, okay, you because part of what I think you're describing is you help the person get to know sort of the why or the motivations for what they do. How much of your work would you say is sort of also includes behavioral interventions? For example, somebody who if they don't eat enough or they eat too much, I guess. I don't know. Not that I can appreciate that you're not starting the session by saying today you're gonna you're not giving them probably like a checklist of what to do. I don't think, but you are likely incorporating some degree of I don't know, sort of interventions or ideas around some type of because it's not the change has to be internal, but it also has to be behavioral. They have to probably make some adaptations there, right? So how do you incorporate that?
Absolutely. One of the things that I think is really important, and when I'm either supervising or giving a presentation, I always think of my work as, and I really think any effective therapy work has to be rooted in both things. I think it's skill building and insight building. I think if and maybe that is slightly controversial, but I do think that in that case, you're able to kind of provide clients with a bit of what they need. And the why and the depth work is super important, but a client has to be stable first. They have to be able to have skills to better, cope with the anxiety that comes ultimately with weight restoration if they're underweight, or
Yeah,
abstaining from purging behaviors. So more of those interventions might be either like environmental modifications, keeping some sort of meal log if they're working with the dietitian, having a concrete meal plan in place and being able to discuss that compliance also in therapy and exploring the barriers and the successes. I think that in those early stages, the behavioral interventions are really helpful.
yeah,
I draw more from the third wave approach. I'm thinking a lot more with DBT, helping client be able to really kind of navigate through those difficult moments, those crisis survival skills, if
sure,
you will. Um, and ultimately just being able to help them really tolerate themselves better and acknowledge that there is change, and change is really scary, but this whole process will result in changes, and it also requires it does require change in
for sure,
that way.
for sure. Um, Bill, I want to get to if maybe if you have some questions, but I just one quick question from the audience. Oh, actually, two. Charlie, one question here is, where would you recommend clinicians get training? So let's say somebody maybe they either want to be kind of have some kind of official certification or right go down that path, or maybe somebody wants to get additional, at least be more informed. Both kind of avenues. Do you have any thoughts about maybe there's no kind
Mhm.
of quick answer to that, but just any thoughts about where might one continue one's education about, techniques or approaches or how to help this client population?
Yeah, absolutely. So there are, and I can also, I don't know if there is a way to like kind of put those
Sure, sure,
um,
sure. We can add them kind of
those.
when we send out the
Sure.
recording, we can add them. So if you share them with me, we'll include them. But go ahead, please.
Okay, yeah, definitely. So I think there are two organizations, really three, that are, I think, the best if you are looking to either just get further training in eating disorders from a clinical lens or just more information. So
Sure.
the first is NEDA, which is the National Eating Disorders Association. They're a great resource uh, for for therapists and just anyone looking to get more information. They provide a lot of resources as well um, for folks who are um, for folks who might be struggling or might be looking for additional support. One of the other organizations that I'm a member of is the Academy for Eating Disorders. So that
Sure.
is um, a group of professionals who, and whether those practitioners, researchers, clinicians in training,
Yeah.
really kind of focus on being able to understand like what are the best treatment approaches and how are those developing? What
Sure.
are what are some of the ways um, in which there are existing trainings for clinicians, and they're usually
Yeah.
always in development. And if you're looking to become an certified like eating disorder professional, um, that or a specialist, it's called a CEDS or a SEDS. That would be through an organization called IADEP, which is the International Association of Eating Disorder Professionals. So that is probably, I would say, for like the most intensive kind of education or
Yeah.
training, it would be probably the best resource.
Thank you. That's really helpful. Right, there's a kind of a range of, depending on what one's looking for or what one wants to learn, but it's nice to know that, one of the things we try to focus on in the podcast is people don't always know where to start. What's a trustworthy
Mhm.
organization? What's a reasonable starting point to learn more? And whether they're a clinician or, a patient or somebody experiencing these difficulties. So I appreciate, we'll definitely include that information kind of in the show notes when we send it out, but that's really
Perfect.
helpful to know. And we're always looking to learn from each other, right? To kind of like participate in sort of community events or conferences or trainings because having that awareness, it could be having the awareness and saying, "Oh, this is a patient that needs specialized treatment," or I can handle it in my own practice, or I need more training. And there's lots of different things that could come up, right? So that's very helpful. Um, One additional question here from the audience is, do you also work with avoidant restrictive food intake disorders? And can you provide any information about, maybe just as a general, can you say a little bit about avoidant restrictive food intake disorder?
Yeah,
And do you do that kind of work, or can you say a little bit about that?
yeah, absolutely. So I I do see some clients with ARFID. They're oftentimes I would say ARFID is most present in like children and like early adolescence, which is not the population that I really work with much right now. But basically, for those who might know, ARFID is a very new diagnosis. Like within the last 10 years, it was just put into the DSM and the DSM-5, like that first edition. So basically, individuals with ARFID um, the disorder itself is marked by a restriction in the amount or type of foods that they consume. But the big difference is that individuals with RFID don't have the same body image concerns as other eating disorders. So RFID is kind of like the extreme of the extreme in terms of like a picky eater. It's more intense than that. So typically the their eating habits are really motivated by just in general, you'll see a lack of interest in food. A person who is very sensitive to certain textures or senses, or tastes,
Yeah.
smells, and oftentimes their RFID is also marked by fear of negative consequences as a result of eating, like choking or vomiting. I would say a lot of clients that I work with who have RFID are emetophobic, which is the big fancy word for having an intense fear of vomiting. And a lot of clients, especially children or adults that you see, there's often a link to kind of like almost a traumatic experience with food. They were eating something and they choked, or a certain taste or smell of a certain food reminds them of a negative or fear-inducing experience from their early years.
Yeah.
So it's kind of it's a complex presentation, and because it's a relatively new disorder, there is still a growing body of research. Do we know necessarily like what the best practice is in terms of treatment? Not necessarily. We have directions. There is CBT for RFID,
Mhm.
which is a shorter term, maybe about 20 sessions usually, of therapy that is really focusing on, symptom reduction, and then the typical kind of, CBT work addressing maladaptive thoughts, engaging in behavior change, how to prevent relapse. Oftentimes, if a child or adolescent is the focus of treatment, is the identified patient, then you'd be doing family therapy for RFID. Those are really like what we see as like the main treatments right now. So I will take more of a cognitive behavioral approach if I'm working with someone with RFID. But right now in my caseload, I don't have any RFID cases, but I have in the past done work with folks with RFID, and they are tricky. They are definitely tricky.
Is it kind of would it be fair to say that there's sort of like an anxiety, there's like an important anxiety component to RFID that's like a
Yes, yes,
okay.
definitely.
Go ahead, Bill, please.
Yeah, if I can just add one thing, because that was actually a question that I was going to raise.
Mhm.
Um, ARFID is the most common type of eating disorder in the autism population.
Hmm.
And and so it is sometimes addressed by occupational therapists who have a specialty in eating disorders and
Hmm.
eating problems in children and younger people, typically younger people with ARFID, focusing sometimes a lot on the sensory aspects of food, but it's not always the sensory aspects of food. So ARFID could sometimes be addressed through ABA therapy or occupational therapy in that specific population.
Yeah. That's perfect, and I'm really glad that you had brought up the OT piece, because I think of that multidisciplinary approach. And I'm thinking of like my postdoc, which was at an eating disorder treatment center, and then other places I've worked since then. For ARFID, there was almost always on the treatment team an OT, um, because so much of that work is something that a psychologist can't really address. It's not within like our purview or,
Yeah.
or expertise. So having that piece integrated into treatment for RFID is really important. And knowing too that you're working typically with younger folks, I'm pretty sure age of onset is usually like between 10 and 12 is the most recent research that I had seen, that you're going to definitely want to work with a clinician who has, a solid base in working with kind of late childhood, like tween, early adolescent populations, and someone that has a good background also in family work, because that's going to be really important to engage the family in treatment for sure.
That's very interesting. Trying to think just in kind of an interest of time here. Well, I I know from kind of some of our earlier conversations, Charlie, that you think of humor as one kind of element of therapy that's important, right? Can you comment on, like therapy is complex, right? There's no one way to describe it, but um, what would a successful sort of treatment look like? The person goes through maybe some degree of self-understanding, changing their behavior, making modifications. Or can you comment on, what the therapy journey is a complex one and it's different depending on the person. But any thoughts about any comments maybe about something like that?
Yeah, absolutely. So, I mean, I think that humor definitely in therapy has its place when used appropriately. I think with eating disorders, a lot of times, like it will come up with clients who, their thought patterns are just so all over the place, and they'll say something in session. I'm just like, did that make sense to you? Because I'm completely lost. And they're just like, what? And then they'll start laughing. I'm like, try this again. Like try this again, or just something to try and sort of keep it light. And that notion of like sometimes just the absurd nature of human behavior, and sort of like, the why are you doing this? Like what is what's going on here? But I think just in terms of my approach,
Yeah,
it really has to be rooted in trust. And I think that that is so important, because an eating disorder develops over time into a safety blanket for a client.
yeah,
And unlike anxiety or depression, where there's more of like that ego dystonic, like the discomfort with the symptoms, oftentimes folks with an eating disorder really embrace the symptoms. They don't
I see.
see the behavior as problematic,
I see.
right? So if you are coming in with the immediate sort of goal of like, let's change this, like
Right.
and I'm here to help you get rid of it, you are going to
Sure.
scare them off immediately,
Sure.
because there isn't necessarily the same urgency, because they don't see this as problematic. So you have to frame it as, like helping, you know, helping them separate from something that did provide them with a lot of comfort,
Yeah.
but we're seeing now that it might not be as helpful anymore. And you're going to be able to, really help them be more likely to continue in therapy and prevent any sort of dropout, or um, uh,
Corruption or something.
just yeah, exactly. And it's really hard, but I think that that has to be the base of the work that you're doing. I think reminding them that it's going to be tough. Um, I always say, like, I think that the best kind of therapy is one where you're challenging the client, even just a little bit, nothing crazy, but really getting them just to, think about something more, reflect on a certain behavior more, talk about something that might not be easy. When you get to a place where you have that rapport, that alliance with the client, they're going to be much more willing to do that. So I really kind of base my work on that approach, and
Yeah.
I think it helps, for sure.
Well, and that really comes through, I think, just kind of the way you're talking. You have sort of a tone of, I can see how the client could connect with your sort of thoughtful, professional, but friendly sort of, you have like a kind of like a caring attitude, right, that you bring into your work where, you're not trying to rush them or change them. You're trying to help them to think about what works, what doesn't, why, how so, when, is there anything they could change? Sort of in a productive kind of thoughtful, challenging way. So I could kind of appreciate just sort of based on a conversation how somebody they could develop a feeling of wow, I could really work with this person, or I could sort of open up to them and explore these things that I'd rather not think about or rather compartmentalize or kind of not deal with, right? Um,
Sure.
one Bill, I don't know if any questions for you. I
No,
I
no.
want I wanted to ask you, Charlie, and this is maybe not a necessarily easy question, but
Yeah.
the world that we live in is um, very diverse in a way where the way people talk about eating or food or what we do with our bodies is so rich. In some ways, in a very positive way. In some ways, you can go on TikTok, for example, and find almost like a rationalization for anything. It could be a rationalization for eat nothing, eat only celery. You know what I mean? I don't know. I'm making this up, but you know what I mean? Like we could sort of, and there's no easy way to define for which individual person at which time in their life and which behavior when is we don't have a we don't have a perfect way of saying what exactly is healthy. We might be more able to say, well, that seems unhealthy. Why? Because of the consequences. But we can't necessarily say, this do this or do that, right? So I wonder how you think about that. Like, how do we engage in the world where, in a sense, it's good that we have a lot of different approaches to life and all that stuff, but in a sense, some of them may not always be that holistic or thoughtful or considerate of the consequences of one's actions. I don't know. Is there any way
Yeah.
that you kind of think about that?
Yeah, absolutely. I think that's a great question because it is, because it is broad. But I'll think of it. I've got some ideas popping up, some things that you can consider from
Sure.
maybe some different aspects. If I'm thinking of like, you know, diversity and culture and who you're treating, right? A lot of times, if you're working with lower income populations who unfortunately are still in who are not served by mental health professionals in the
Sure.
same way, especially in the treatment of eating disorders, it's very, when it comes to like meal planning or something of
Mm-hmm.
that nature, you have to recognize that so many, folks who are lower income are living in food deserts or don't have access you know, to
Sure.
nutritional foods in the same way. So if you're just kind of making that assumption that a client is going to be able to obtain food
Right.
or food insecurity, that is something too that I have to, that I'm trying to keep in mind. So
Yeah.
there's that aspect of things. You think too right now the influence of social media. There's this pretty solid body of research developing that, you know, social media exposure can increase body image dissatisfaction, and that
For sure.
in turn increases risk to develop an eating disorder. And we have folks who call themselves influencers that talk about this notion of being skinny, right? And we think of the thin ideal, and especially how pervasive that is
Sure.
among women. And then kind of as I was talking about earlier, we think with men and boys, there's that internalization of like the muscular
Right.
idea,
Right.
right? And so comparison when it comes to the notion um, of size
Sure.
and weight is something that can be so harmful, so poisonous.
For sure.
And it can be really hard to suss out what is actually body positive online if you're thinking that way, or
Yeah.
who are you listening to, who are you watching, because there are on social media there's some excellent psychologists or dietitians or people who work in the ED field, and they're
Yeah.
great sources of information. There are also many, many, many accounts and influencers and people who make claims about what they do and they are harmful. They're manipulative. And so we have to recognize too that the context in which our clients live now is so different. And I feel like it changes and gets even harder to follow. It's like every month,
Right.
something
More complex,
is
for sure.
changing. Yeah,
I
absolutely.
also think it is or isn't surprising that this process starts earlier in life than we would maybe think about it. We might think about it as being an adolescent, kind of emerging in adolescence, but from my experience, I see these issues frequently arising in pre-adolescence and middle
Yes.
schoolers. Yeah.
And you're absolutely right, especially with more restricting presentations. Um, I'm thinking back to kind of the history of clients that I've worked with, especially in higher levels of care. And I mean, I've seen kids as young as 9 who have had to be hospitalized with
Right.
NG tubes, feeding tubes. And I remember there was like a 72-year-old woman on the inpatient unit who, after a series of traumatic events and then the death of her husband, turned to food and developed pretty severe binge eating disorder, and to the point where she was really no longer able to function. Then there's severe depression on top of that and everything else,
Right.
right? So it is really such a wide range of ages that you see. um, but I think something that, and this is still very much, whether you want to, what stigma or just how we perceive the face of an eating disorder, we think of like the, gaunt, emaciated, exceedingly, thin person. If you were at a residential treatment center, really at any level, actually, really any level of care, 95% of the people that you see, you would never look at them and think, oh, this person has an eating disorder. They look exactly like you
Mm.
and me.
Yeah.
But it's the internal damage that is being caused. I mean, eating disorders are the number one leading cause of death among the psychiatric illnesses. So, that you're not going to see the the media's portrayal of what a person with an eating disorder looks like
Right. That
very
makes sense.
often.
For sure.
So that's also something that I always like to clarify, and I think it's important that the face of an eating disorder just can look like us.
100%. Right. Charlie, there's so much useful information here. I just in the interest of time, we got to come up, we got to close for today, but I
Mhm.
want to express my sincere appreciation. I think it's a really rich
Mhm.
topic. You have a
Yeah.
very nice way of kind of talking about the field and your approach. And so we'd love, maybe we could plan to have you back at some point and kind of talk more about it's a very, I think it's a topic that's not talked about enough in terms of
Yeah,
the healing power of what access people have to getting help, and
Right.
important to kind of keep in mind. So just wanted to express my appreciation
yeah,
for coming on the podcast. We'll include the information you mentioned, and kind of and we can include your practice information if you'd like, if in case somebody has a question or maybe they want to connect.
absolutely.
I think you're such a great resource. So just want to
Anytime.
say
Yeah.
thank you
Yeah. It's great.
for joining us and for this conversation.
Thank you for having me. I was looking forward to it, and I think for me, I always like to be able to, um, not really even just sharing my experience, but just
Sure.
the complexity of these disorders, but also just how sometimes, even though they are very complex, they are deep, that when you have a solid therapeutic base, you can do really powerful work. The training can come, the specialty can develop, and all of that. But these are people that just want that. They want the therapeutic support just as much as anybody. Not always as easy to engage, but when they are at that point, they want to be heard, they want to be helped, they want to be
Yeah.
supported. And when you can do that, you're already that's half the battle right there.
That makes sense. Well,
Yeah.
Dr. Starkman, thank you so much. Really nice
Thank
to
you.
connect with you.
Thank you.
We'll
Yeah.
let's stay in touch. This is a really great topic. So thanks for your time.
Yeah,
Thank you.
absolutely. Thanks, guys.
Take
Appreciate
care.
it. All right.
Okay.
Bye.
Bye.